Welcome. As I identified, I'm a physician who's a specialist in internal medicine at Toronto General Hospital and a proud member of this hub, Echo Coping with COVID. And today I'm going to review some of the things that we can anticipate seeing in the coming months in all of our personal and professional lives. I'm going to lean on my colleague, Dr. Alison Crawford, to help navigate some of the conversation pieces that we'll have in the discussion afterwards about the impact on mental health posed by the pandemic and how we're going to prepare for its aftermath. I have absolutely nothing to declare, and I have not received any third-party support, and I have no conflicts of interest, and everything that I share is rooted and based in evidence and is not a personal opinion. I'm going to start by reviewing a timeline of the past 16 months. So this is meant to be a kind of narrative and picture-driven review. And I ask all of you to reflect on the emotions and experiences that you have as I go through these slides and populate in the chat dialogue. I'm going to outline the impact that this has had on physical and mental health in a lot of our patients, in ourselves, and in our practices. And then I'm going to outline some strategies aimed at managing this outcome. So I start with a reflection on the months that preceded the declaration of the pandemic and preceded the changes to our healthcare system and way of living in Ontario, Canada, and throughout. And so this is the believed to be purported timeline of what led to COVID-19 being declared a pandemic by the World Health Organization. And I know that all of us during those months were living a life very different from the life we live now, both at home and at work. And I want you all to reflect on how things were and how drastically they changed very quickly when the state of emergency was declared. And I'm taking a pause right here, and I'd ask you to populate in the chat dialogue some of the feelings and emotions that you had thinking back to that fateful day on March 14th when this announcement came out, and when we started to realize that things were going to become very different and uncertain. Many of you will remember what you were doing on that day or the day before, and many of you might remember what you did in the weeks following that, both at home and in your professional lives. What messaging did you get from the clinics that you worked in, from the hospitals, and from the government as it pertained to your job? What messages did you get from your professional bodies and your unions about what to do and how to act? How did you feel? Please share that with me. In the weeks and months that followed, there's a lot of images that we can all remember that came through our consciousness. This is a picture of an overcrowded hospital in Italy where they saw a high surge in COVID-related cases and mortality. The hospitals were full. They were running out of oxygen. They were running out of ventilators. They were getting creative. And what you can see here is when they were connecting one ventilator to two patients, when they were using masks around CPAP machines as means of optimizing oxygenation. They were getting creative because they were faced with very high amounts of disease burden and very high numbers of cases in frail elderly patients. Remember the rush to PPE, the fear and anxiety about running out of masks, gowns, goggles, hand sanitizer. Remember those rushes and fears at hospitals, clinics, and the rushes and fears at Costco and Walmart. The instant shift to virtual care, how quickly many people adopted to this model, and how governments and professional bodies changed compensation, remuneration to facilitate and allow clinicians to provide care from home. The school shut down. As a father of three, who could not forget this school shutdown? Oh my goodness, what are we going to do? And I have to work during this pandemic, and my wife is a frontline care provider. What are we going to do? Businesses shut down, the angst and frustration experienced by the business community, people's livelihoods changed suddenly. And why did we do all of this? Flattening the curve, that was the buzzword way back when. in March of 2020 when this came out. And the purpose of flattening the curve is to maximize our healthcare system capacity and minimize the chances that we get to the point where we oversee this, where we end up like those pictures in Italy and we don't have enough ventilators to go around, we don't have enough oxygen, we don't have enough people to work these tools, these machines, and care for those patients. That was what flattening the curve was about, was putting in protective measures, shutdowns, restrictions, so that we would not oversee our healthcare system capacity. And as someone who sits on various critical care boards, at that time, there was a fear and a concern that we were one logarithmic scale short of ventilators in our province. And this was based on early modeling. So we were about 100-fold off of the amount of ventilators that we needed. That was the fear and the concern. And that was what we were thinking in early March. If you look at what happened retrospectively, this is the spike in deaths that were experienced on the yellow curve compared with the baseline expected death rate on the black and gray. So the black represents the monthly and weekly deaths that were described in Ontario in 2019. And the yellow and orange reflects the deaths in 2020. You see the spike between March and June. And interestingly, a little bit of a drop later on, which we'll comment on afterwards. When you looked at what was happening during that case in time, if you looked on the left side of this picture here, we see the total cases in Ontario between January and May, about 26,000 COVID cases, with about 4,800 in long-term care residents and 1,700 in long-term care staff. On the right-hand side, we see the total number of COVID-associated deaths of 2,000, with a very large proportion of those deaths being reflected by residents in nursing homes. We all remember this point in the pandemic. We all remember the pictures and the stories and tales from long-term care centers in Ontario and throughout the country. Looking back on that spike in deaths, that excessive 7,576 deaths, a large percentage of those were COVID related. In fact, 8,345 people who died of all people who died associated to COVID. Interestingly enough, over half were aged 85 and older. And I provide some of the other age ranges of the deaths associated with COVID during that point in time. Here's a slide that outlines up until COVID, the expected life expectancy in Canada. So we see that the average life expectancy is about 82 years. Different for women, different for men, different in certain socioeconomic statuses and demographics. But remember that the average age that one is expected to live is in the low 80s. The average age of patients who died related to COVID was above 82. After all of that, we saw the first wave recede and we started to talk about a framework for reopening, stages. Hospitals had a framework for ramping back up services and reintroducing visitors. So we all remember these stages, these color-coded sequences and schemas that were introduced, both for the community and for our hospitals and clinical environments. And what was the purpose of this lockdown? Well, not only was it about minimizing our burden on the healthcare system, well, it was about reducing the COVID infection risk. So by shutting things down, we reduce the COVID infection risk because we're limiting social interaction. We're closing restaurants, we're closing bars, we're closing mass congregating events, weddings, funerals, you name it. But what happens is when we reduce our risk of COVID infection through these measures, we increase our risk of things like social isolation, loneliness, and the impact on connectivity. And I know that myself, Heather, Allison, Sanjeev, we've all talked about the impact from a mental health standpoint with respect to these specific parameters related to the closures in the context of the pandemic. So we're always trying to balance this with our shutdowns and our reopenings. As we've talked about before, loneliness has significant impact on health. As harmful to your physical health as smoking 15 cigarettes a day and associated with the same degree of mortality. It increases blood pressure, increases the incidence of requiring disability, and has cognitive effects as well, and significant mental health impacts. After that first wave, the race to the vaccine was on. We looked at the various vaccines that were in development, and this was in mid-2020. We had many vaccines that companies were working at various phases of delivery and phases of study, keeping in mind that most vaccines take about 5 years to develop, to study, and to implement. And we were working feverishly on this. Good thing we were, because just when we thought it was over, we saw the second wave. And we can all remember that feeling, that pit in your stomach, that anxiety, when the case count started to increase and increase and increase in the fall. And we knew that decisions were going to have to get made, similar to those made during wave one. And we were only picking the pieces up for that. Fortunately, everybody was hoping for this vaccine, hoping that some of the treatments we have created would help treat this virus, combat it. But we knew that we were in for another ride with wave two. Kind of felt like a roller coaster. You just started to feel like you got over that big crest. You were catching your breath. You know, that summer of 2020, people were out again. People were walking outside, not wearing their masks at the outdoor restaurant. And then you started to feel the jolt as things started to go up again, uncertain about how high you would go on this ride. Fortunately, as wave two started to recede, we had some great news. Vaccines came out. A vaccine was created. The whole world worked together, scientific experts, leaders in community and government, to develop a vaccine that had significant amounts of promise. And we delivered our first vaccine in December 2020 to a healthcare worker, a personal support worker in a long-term care center. So finally, this excitement that we'll have a vaccine, the end is in sight. Look at the news headlines. I don't know if anyone's seen the movie Palm Springs, but it's great. And essentially, this couple lives the same day over and over and over forever. And that's how I felt in March when wave three came back to get us. We started to talk about things, very serious things, and I shared that with all of you in one of the echo sessions that we had about the emergency standard of care. And this was when we were talking about implementing a strategy to essentially have a doorman at the door to the ICU, deciding who would get access to the ICU and who would get access to those resources and who wouldn't, and who would receive palliative care alone. These were very serious conversations, very intense discussions that happened at very high levels of government between the critical care groups and the Senate. And we almost had to implement this during wave three when we were running out of resources, case counts were getting high, and we had those variants to worry about. And those variants are going to be something that we're going to have to continue to worry about as time goes on. Looking at the impact on resources, we can reflect on running out of oxygen and the fear with that. Los Angeles almost ran out of oxygen. We had various states and various cities that ran out of critical care capacity. In Ontario, we are transferring people between hospitals on a daily basis. Some days we were moving 15 patients a day out of ICUs in heavy hit areas to ICUs that were 1,000 kilometers away. We're using critical support services like Orange to transport these patients, taking them away from things like dealing with roadside accidents, which interestingly may have been reduced with all of the shutdowns and may have led to that drop in mortality that I showed earlier on. This was burning everybody out, being asked to do more with less. Nurses given blackout periods for vacation dates and times, redeployment, the chronic stress and anxiety of working in these environments, and providing care for the sickest people in the country. Not only was COVID disastrous to our economy, to our way of life, and to the hospital system as it pertains to managing these patients in the ICU, but I'm sharing some data here from my hospital, from the University Health Network, of which Toronto General is a part of, about what this meant for surgeries. All of those people waiting for knee arthroscopic surgeries, waiting for colonoscopies, waiting for hip replacements, they all got put on hold when wave one happened, and we started to ramp them back up, but to put them back on hold with wave two, and again with wave three. And what you see, this is from the end of the month in June 2021, is we have a huge backlog of cases in orthopedics, plastic surgery, general surgery, spine surgery, and these are all of the quote unquote non-urgent cases. Depends who you ask. If you ask the patient suffering with arthritis who's unable to move their hip, this is a pretty big deal. There's a significant backlog right now of close to 4,600 cases. 1,000 of those are oncology cases, just at my hospital, at the UHN. When you look at this graph here, without getting into the nuts and bolts, we essentially have an acceptable backlog in cases, and that's the red line at the bottom. And the blue line is the actual cases. And there's always a bit of a backlog because emergency cases bump people off. There might be issues with staffing in the ORs that limit the amount of staff available to help. There's an acceptable backlog that we can make up. But if you look at the blue graph, we have a very unacceptable level of surgical cases on backlog at the University Health Network. Not only were surgeries impacted by this, but everything else was impacted. And as I talk about these final few slides, I'd like you all to share in the chat some of the other things that you have seen impacted by these shutdowns in your practices, in the communities that you serve, and in the hospitals that you work in. Cancer screening was really impacted by COVID-19. Just looking locally in Kitchener-Waterloo, which is a snapshot that is pretty much on par with other areas throughout the entire province and country, we saw a huge drop during that period of wave 1, 98% decrease in mammograms, which are screening tests for breast cancer, 88% decrease in Pap tests, which are screens for cervical cancer, and a 72% drop in the tests for colon cancer. So just imagine, are we missing the early detection of cancers? Will they present at a later stage of disease, at which point their outcomes are far worse, at which point the cost to the system is far worse of helping a patient with a stage 3 cancer versus a stage 1 that would have been detected early? When you ask the patients and you polled the patients, some surveys were done, and there's a particular survey here that revealed that half of patients receiving cancer care had their appointments canceled, postponed, or rescheduled because of COVID-19. 74% of those surveyed reported that delays in appointments and treatment had a major impact on their mental and emotional well-being. Many were worried, stressed, and anxious. And not only were patients missing their appointments and scheduled visits by virtue of disruption to the system, but many of these cancer patients were very apprehensive about going into the hospital to seek help and seeing their primary care oncologist to seek assistance and help for fear that they might contract COVID-19. And we saw a huge drop in emerge visits at all of the hospitals that I work at, and a huge drop in new referrals because patients simply weren't getting out and weren't going seen. They were afraid of the hospital system. If you look at some of the other downstream impacts of this pandemic, we can see that a large proportion of patients in our community reported gaining weight. And in Canada, the numbers actually fared far better than in Europe and the United States. In the United States, over half of people surveyed in most large-scale surveys reported a weight gain of 10 or more pounds. The impact of school closures increased the amount of anxiety experienced by all of the parents, impacted the mental and physical health of parents during this pandemic, increased the amount of mental health support that patients needed, and increased the amount of mental health diagnoses that were made in parents of children affected by the shutdown. Children, parents, everyone was impacted differently. And if you look at Gen Z and the college student population, who describe education as being a significant source of stress, many of them felt a high degree of stress and uncertainty around the closures and impacts to their college life, their educational development, and their futures. People predict other trends as well. My colleague Rafi Rush, who's a physiatrist, internist working at Toronto Rehab Institution, published a great editorial in the Globe and Mail. Sure, our ICU numbers are going down, and they are going down. Actually, we have 0 COVID patients right now at the TGH ICU with active COVID. But where are they all going to go when they recover from weeks and months on these specialized services and care with critical illness polyneuropathy, the 203 symptoms associated with COVID long hauler symptom? These are all going to be people who place a burden on our rehabilitation services. So I ask you to look in your crystal ball. Reflect on some of the trends and some of the things that you may anticipate seeing in your patients and your community as a result of these system-wide shutdowns, as a result of the ongoing issue around variants of concern and the imperfect vaccination rates. We're pretty good in Canada, but we're not batting what we need to for herd immunity. So with that being said, now that we have this information, this data, this experience, it's not time to be surprised by what's coming, but it's time to be prepared. And I'm hoping that we can have a good discussion after this, facilitated by myself and Allison, to outline some of the ways that we're all going to prepare in our practices for this and in our personal and professional lives. Some of the specific action items that I ask you all to reflect on are the importance of code status and advanced directives in the office. What we learned with Canada's ethical strategy about COVID was to prioritize the number of lives lost with the vaccination strategy over the quality of lives lost. If we saved the life of someone in their 80s by these measures or with the COVID vaccine, will their life be forever changed because we treated this patient in the ICU and they're markedly debilitated? Do we have those conversations with our patients about quantity versus quality? Now that we have that information, these lived experiences about COVID, perhaps it's time to have those conversations with our patients. Talk to your patients about the weight they may have gained and some weight management strategies in adopting a healthy lifestyle. Recognize how frequent mental health afflictions are and have been due to this. Use your mental health screening tools. Ask your patients and clients about substance use. For the children, what is the impact of this shutdown on schools? Some people fear increased rates of delinquency and incarceration 10 or 15 years down the line. Decreased GDP and the economic impact of these children not developing appropriately, not being screened at schools by social workers and teachers. So what can you do in your offices and practices to nurture and screen these individuals? From a cancer screening standpoint, bring your patients in if you're a primary care provider, make sure their screening is up to date and offer it to them. And ask them about how this pandemic and the closures have impacted their well-being and their degree of isolation. I provided some references there. I'm now going to end my talk. I'm going to stop sharing the slides. I appreciate all the attention that you've given during this talk, and I look forward to the discussion that will ensue.